for success.
Thank you for having me here. Obviously, I'm a little bit of an outlier in this session now. Back to small surgery, I guess. So, and also looked at the program. I know Srino is up later on, probably with a very similar topic. So there's going to be some overlap, hopefully a little bit complementary as well. But I'm going to talk about hyperarthroscopy in this dysplastic patient. I think we had a good discussion this morning about instability, so I'll just leave it at that. I think we don't really know where we are. But I think the basic premise for this talk is, in this setting, you want to have a high-volume arthroscopist, an expert arthroscopist during the surgery. So you want to get in and out fast. You don't want to have somebody who's traction time of 50, 60 minutes, 2 hours, 25, 35 minutes, somewhere in that range. I think it's bad because you want to minimize soft tissue insult and swelling if you're doing a concomitant PO as well, right? So why would you scope? Well, you want to be able to address intra-articular problems, cartilage, lipopathology, and impingement. You want to be fast. You want to minimize insult to soft tissues because one of the biggest reasons for revision arthroscopy is adhesions, right? So you want to make sure you don't cause more damage in there. So not everybody needs a scope. I think we discussed it this morning as well. So you want to minimize iatrogenic micro or macro instability. And hyperarthroscopy cannot fix bone instability. So if bone instability is there, you want to think about the PO, obviously. So we're not going to talk really of diagnosis. I'm going to mention briefly dynamic ultrasound and some of the three-dimensional imaging. But this is not about making indications, this talk. The assumption is decision is made to do the arthroscopy, either alone if a stable borderline dysplastic patient or in combination with PO if that is concomitant or staged, and to focus on a technical purpose of arthroscopy. Just want to go briefly to dynamic ultrasound. I mentioned this briefly this morning. But basically, this is you take a patient to an apprehension position and kind of measure the femoral head translation. So while you're dynamically moving the hip, so it gives you some sense of instability in the broadest term, right? And also, while you're doing that, you can do a nice injection. So again, you want to confirm before you scope that there's some really intra-articular etiology of pain. So I think that's really important, and Jeff mentioned it this morning as well. So three-dimensional imaging, we talked about this a few times, very important, particularly in this setting. You want to have acetabular femoral version, ideally also address or look at tibial torsion. So this is for surgical decision-making, not necessarily for planning. So this is one of the means, and then started using more and more this technology, where it allows you as well, again, acetabular femoral version, more information, much more information than you can get from radiographs. And then here it allows you to incorporate some of the translation, as you see here, into defining the level of instability, also in different flexion and extension motions. And then here it also gives you, in general, some impingement information. It's also important, obviously, in the peripheral compartment, if you're doing a scope, to address all the pathology there. And here, vacuum sign, so Josh will be happy. So technical pearls, the way I break it down is access, capsule management, label management. I'm not going to talk about the rim lot because in this setting, dysplastic patients probably don't want to do a ton of the rim. Subspine impingement you want to address, or if you have an everted labrum, you might do an advancement, address some bony side here on the acetabulum. But otherwise, it's just access, capsule management, and label management. So basically you want to beware of the hypertrophic labrum. So it obstructs your view, and not everybody obviously has an hypertrophic labrum in dysplasia, but it can obstruct your view and access. So I would probably not have one of the trainees do access in this setting or the PAs. You want to really harp on that tactile feedback here. You want to feel what's going on once you go through the capsule, where's the needle. You want to have a good sense and feel for that. And also I feel in this setting, particularly the DALA is a very important tool. So the DALA portal, if you look here on the left, that picture, you see a switching stick and a drill guide, so different angles coming into the joint. Obviously, in dysplastic patients, you're dealing with a shallow acetabulum. You don't want to perforate into the joint. So curved drill guide and the DALA portal probably a good idea in this setting. Capsular management, interportal versus T-capsular versus periportal, it depends, right? So if we're talking about doing a capsular incision in borderline, stable borderline dysplastic patient, and no PO, I think capsule plication and shift, very important. If you have an unstable borderline dysplasic patient, frank dysplasia, so in combination with PO, I would only do a closure. Paul Boulay had this really nice paper overview of the different types of capsulotomies, what they entail and what the result is in terms of stability, range of motion. So it's really a good summary. I always have the fellows read that as well. And obviously I can't give a talk here without having one of Ben's many papers. And so this is a beautiful technique about capsule plication and shift I would incorporate in a borderline dysplastic patient where we're trying to stabilize some of the soft tissues. Here's the way I think about that. So I rarely ever perform a T-capsulotomy these days. So some people might make the argument if you have somebody who's unstable, you have a better chance of tightening up, plicating the hip if you have the vertical limb of the T-capsulotomy as well. So I would say to that, if you have somebody who has connective tissue issues and you make a bigger cut, maybe there's a higher risk of non-healing. So for me, in my hands, minimal interportal capsulotomy, and also in combination with suspension sutures to lift off the capsule, minimize insult to the capsule, have a thick capsule at the end of the procedure. So getting the capsule out of the way while also allowing you to have good visualization of the rim. So at the conclusion of the procedure, you want to plicate the capsule if you want to stabilize it. So again, it's not the one you're going to do a PAO on. So 4 to 5 side to side is non-absorbable for me. Perform a capsule shift, application. You can also consider a figure-of-8 pattern for the sutures. And then you can also consider trimming back some of the capsular tissue. So when you close it, it is also more of a tightening plication. You want to close it in flexion. And then greater degrees of flexion, interrotation, you need to be cautious because you don't want to over-tighten. So importance of recognizing and respecting the osseous instability in the setting or dysplasia in the setting. The most meticulous, well-performed closure cannot take care of bony instability. And you want to be cautious in treating patients who have frank dysplasia, obviously, retroversion, increased anteversion, and the acetabulum. And the risk factors also, just observationally as well, is, if you have somebody who has disability, a lot of disability, not able to walk, minimal to no impingement on physical exam and imaging studies, I would probably be cautious considering arthroscopy in this setting. So labral management, again, the general principle of labral management in any hip arthroscopy apply here as well. Repair versus recon, augmentation, so you want to have a good labral suction seal because the seal also functions as a stabilizer. Place the anchors close to the rim to avoid eversion of the labrum. Create a good suction seal. Use curved drill guides and or DALA as needed. And if you have difficult visualization getting in, what I do is if you have this large labrum in your face, I'll start with about 12, 12:30, somewhere there, a clock position suture, loop it around, and bring the labrum back, bring it out of view, because in that section, typically, so say 1 o'clock, 12:31, the acetabulum rim is pretty wide, so it's a safe zone in my end to put the labrum in, then reduce it, and then you can work your way back and forth and stabilize the labrum otherwise. Hypertrophic labrum can throw off also the depth perception, I feel. So you have a good, usually if you have a normal sized labrum, the depth perception where the drill guide will go is different than you have a large labrum, so it can throw you off a little bit. So again, the DALA I think can be helpful here. But also you want to prepare the rim nicely with some rim trimming, know exactly where the anchors go or the condylabral junction, and the rim is where it ends. Hypertrophic labrum, for me is a low threshold to augment in general, particularly also in this setting, and reconstruct because you want to have that suction seal. Everted labrum, one of the things is you want to consider a labral advancement. So you don't want to cause iatrogenic instability or dysplasia. And again, low threshold for augmentation reconstruction. And the way you manage that everted labrum, apart from the advancement, from the bony side, you place the anchors inside underneath the labrum, so you kind of cinch it down into the joint. So in general, in summary, so you want to perfectly manage the FAI, so CAM. You want a perfect management of the labrum, so is that a repair, is that a reconstruction, augmentation? You want to have that suction seal. And capsular management is plication if you're not planning a PO. Otherwise, I think you can do just a closure. And then do not debride the ligament tears. Do not do an iliopsoas release. Don't leave the capsulotomy open, and don't over-resect. Thank you.
Thanks, Tom. I think we'll open it up for questions now.